Hello friends. Now today we'll discuss about the community acquired pneumonia. Before discussing about the community acquired pneumonia, I'll further explain you that we have already discussed about the pneumonia, what is the type and what are the causative organism and what are the pathogenesis. Normally you should understand that normal individual usually mainly in the elderly people, if they are sleeping, then at that time also there is the micro aspiration is going on. When the patient come in the hospital during intubated or in ventilation, although there is a intubated tube, endotracheal tube is there, but it prevents from the large amount of aspiration by endotracheal tube. But the small amount of micro aspiration is going on in ventilated patient as well. And in normally, not in the healthy people, but in the elderly people, during sleep there is a micro aspiration is going on. So you should always consider that why a patient comes to you with pneumonia. There will be some seasonal virus, then exposed to some infected person, but it doesn't require to be exposed to the infected person as well. Sometimes the micro aspiration during sleep can also be responsible for pneumonia. The micro aspiration of your oropharyngeal content can goes into the sterile region and the process again of pneumonia, which we have discussed about the pathogenesis. I will again come to the community acquired pneumonia, and I have already discussed that community acquired pneumonia means a patient in the community who has not been exposed to antibiotic in the community or has been admitted to the hospital in past 3 months. That is called community acquired pneumonia. Okay, there has been classified as a lobar pneumonia, bronchopneumonia and interstitial pneumonia. According to the causative organism, lobar pneumonia was Streptococcus pneumonia, Klebsiella and Legionella. These are the organisms that can be responsible for the lobar pneumonia. Then there will be the bronchopneumonia, there will be the patchy consolidation, and the organism again responsible are Streptococcus pneumonia, Haemophilus influenzae, Staph aureus and Klebsiella. Where that of the interstitial pneumonia, they are the atypical organism known as the Mycoplasma pneumonia, Chlamydia pneumonia and Legionella pneumophila. These are the organisms that can be responsible for the community acquired pneumonia. Okay, when you goes to this is a chart from the Harrison, where this is listed in a Harrison, a chart that is outpatient, what are the causative organism, and hospitalized patient, non-ICU and ICU patient, what will be the causative organism. There is Streptococcus pneumonia is in all patients, here in outpatient, in non-ICU, in hospitalized patient, ICU hospitalized patient, everywhere there is Streptococcus pneumonia. Okay, then outpatient Streptococcus pneumonia, Mycoplasma pneumonia, Haemophilus influenzae, Chlamydia pneumophila, respiratory virus include influenza, parainfluenza, respiratory syncytial virus, human metapneumovirus. These are the causative organisms that is responsible for outpatient community acquired pneumonia. Okay, the hospitalized patient with community acquired pneumonia, the organism will be almost same. There will be Streptococcus pneumonia, Mycoplasma pneumonia, Chlamydia pneumonia, Haemophilus influenzae. The additional will be that Legionella. I have already discussed that Legionella are the organism that is responsible for the water system. Normally, this Legionella was once there was a meeting in US, and in a place called Legionnaires disease, it is known as that. There was a meeting, and from BSc, the SC water was infected, and every person in that meeting was get infected with this bacteria, and after that it was discovered and named accordingly. Okay, so it is required the water system to be get infected, exposure to water system. It doesn't mean that you working in the AC room in your working office and somewhere there also you can get this Legionella bacteria, sorry. And then there will be the respiratory virus again, all this influenza, parainfluenza, respiratory syncytial virus, human metapneumovirus, these all are there. Okay, in ICU patient there will be again Streptococcus pneumonia, then Staph aureus should be considered in ICU patient. Legionella again the same. Gram-negative bacilli now comes into the action. Here we cannot see in the OPD patient and non-ICU patient, but when it goes to the ICU patient, then gram-negative bacilli also comes. Other R will be the Haemophilus influenza and the respiratory virus. That is all. You should also consider in community acquired pneumonia about the Pseudomonas aeruginosa and community acquired MRSA. We'll come to it one by one. Other okay, during the management. The additional point what I want to say about the community acquired MRSA is that there are MRSA, you know, the methicillin resistant Staphylococcus aureus. Staph aureus is a very nasty bug. It is a very virulent bug. It is very virulent organism. It can cause infection of everywhere and it is very pathogenic. Okay. Among that, MRSA means it is methicillin resistant. It is resistant to many of the penicillin that we have to understand. Okay. So we have a very limited treatment option for MRSA. And the MRSA can be community acquired MRSA and hospital acquired MRSA. Hospital acquired MRSA is the portion that is the difference between two is that hospital acquired MRSA are more resistant one, but community in comparison to the community acquired MRSA. So community acquired MRSA, if a person comes with a community acquired MRSA, say pneumonia or any part of the infection, then you will what is the difference is that you will find that MRSA, community acquired MRSA, is sensitive to some of your antibiotics like cotrimoxazole, TMP-SMX or clindamycin, doxycycline, and other usual organisms that are usual antibiotics that are sensitive to the MRSA are vancomycin, teicoplanin, linezolid, daptomycin. These are the drugs that are the drug of choice for MRSA. Okay. So in comparison to the hospital acquired, you may not find that MRSA is sensitive to this cotrimoxazole, clindamycin, and these are the drugs. But what is the main difference? You should understand that community acquired MRSA is more virulent than comparison to the hospital acquired MRSA. Okay, hospital acquired MRSA and community acquired MRSA. This community acquired MRSA, although will be sensitive to few drugs more than that your hospital organism, but this is more virulent, more pathogenic and virulent. Why? Because it contains two things. One is super antigen. That is enterotoxin B and C. And another point is it contains PVL. What is this PVL? PVL full form is Phantom Valentine leukocidin. What is this PVL? Phantom Valentine leukocidin. This is a toxin. This toxin has a special characterization of damaging the neutrophil, macrophage, and monocyte. So it is leukocidin, that is, it lyses your defense mechanism, defense cell, phagocytic cell. Suppose you have a neutrophil, macrophage, anybody has got infection in any part of your body, this neutrophil, macrophage come and play a role to manage that infection. But when you are having infection with this CA-MRSA, then you should always be careful that this CA-MRSA will be more virulent, more toxic, and due to the superantigen present with it and the Phantom Valentine leukocidin toxin present in it. Okay. So you should consider this community acquired MRSA more seriously. That is my point, and management will come one by one. So we have came to know about this organism. Now let's deal with the management part. If somebody comes to you, okay, now in the ER on the OPD with signs and symptoms of pneumonia, patient is having fever, toxic, dyspneic, you are examining. On examination you can find, if you are examining carefully, there are the 4 stages of examination of a respiratory patient, that is inspection, palpation, percussion, and auscultation. In inspection you will see the chest expansion and the shape and size of the chest and any deformities there are not. Then it comes to the palpation. In palpation, you see the position of trachea. Normally, if you are having pneumonia, then position trachea is not going to change. It will be in the centrally as well, where it is. But when you have a collapse, then it will pull your trachea towards the same side where the collapse is. If you have a pleural effusion, then it will push it into the opposite side. If you have a tension pneumothorax, then it will push to the opposite side. So in pneumonia, it will be central. In case of the collapse, it will pull towards the same side. Okay, suppose this is a right-sided collapse, then right side the trachea will be shift. If there is right-sided pleural effusion or pneumothorax, then it will push into the opposite side. That will help us by knowing that position of trachea. Okay, then there is the other examination like vocal fremitus. Vocal fremitus, since the lung parenchyma has gone solidification, consolidation, this vocal fremitus will be increased. It will decrease in pleural effusion and pneumothorax. Okay, and then you come to the percussion. When you percuss, that the area over the consolidation there will be dull, woody dull. Okay, in case of normally when you percuss, the sound will be resonant, but in case of pneumothorax, it will be hyper resonant. In case of consolidation, it will be dull, woody dull. In case of pleural effusion, there will be dull. It is called stony dull. So you just don't confuse in woody dull or stony dull. Just dull in case of the pneumonia and pleural effusion, but in case of pneumothorax, it will be hyperresonant. So you can examination and came to the end auscultation. Come in auscultation, the mnemonic finding, you will have that bronchial breath sound. I have explained that since this lung parenchyma has undergone solidification, consolidation, they will come in. There is no gas exchange, and it will again go back. Come, pause, go back. This is bronchial breath sound. Then other feature will be there will be increase in this whisper pectorally, bronchophony, egophony will be there. Okay. So these are the findings which you will come to know, and then you do X-ray, you investigate, you do the blood count and other thing. You do examine the sputum for gram stain and culture and etc. and etc. So you came to know that he is a pneumonic. He is from the community. Now community acquired pneumonia has been diagnosed. Now you need to decide whether he needs to be get admitted or you can treat in outpatient. So for that we have two index. One is the pneumonia severity index and another is the CURB 65. So you have known about these two. At least CURB 65, I think you know that. Okay. So PSI, what is this? Is pneumonia severity index. It has actually 20 variables. 20 variables are there. In 20 point you should consider and classify into 5 class. 1, 2, 3, 4, 5. You are getting my point? So this, what are the variables? Mainly includes age, comorbidities, then other things are in the physical and laboratory lab abnormal finding. So these are there are actually 20. We are this is comorbidity, physical and laboratory abnormal finding are included, and according to that, this pneumonia severity index is classified into 5 class, and among 5 class, class 1 and 2 can be treated in OPD, outpatient setting, in home. But when it comes to the 3, 4 and 5, you have to get in hospital. You have to treat him in hospital. You have to hospitalize the patient. Okay. This, since having the more variable in the busy ER, you cannot be able to use this index, this score. It will be difficult for you. For that, we have another score called CORB 65. It is a score to know the severity of the illness. And CORB 65 includes C for confusion, U for uremia greater than 7 millimole per liter. Then R for respiratory rate greater than 30 per minute. Then blood pressure systolic less than 90 and diastolic less than 60 mmHg and age 65. These are the full form. C for confusion, U for uremia, urea level greater than 7 millimole, then respiratory rate greater than 30 per minute breaths per minute. If blood pressure systolic is less than 90 mmHg and diastolic is less than 60 mmHg, and age is 65. If among the 5 points, if you are having 0 to 1, then you can treat the patient in outpatient in the hospital. No, in the outpatient means in the home setting. But 0 to 1, home or out of hospital. CURB curve 65. So 0 to 1 out of hospital. 2 hospitalized. 3 or greater than 3 ICU. So you should be clear about it. When you are seeing this patient and your patient is having any of these 5 components, you point it out. If there is confusion, uremia is there, respiratory rate is greater than 30, blood pressure is low, and age is 65. If 0 to 1, treat the patient outside. If 2, hospitalize it, but it isn't required for ICU admission. But if there is the 0.3 or greater than 3, you have to admit the patient in ICU and then manage accordingly. Okay. Now let's go to management part. There are two major guidelines which we have to know. One is IDSA guideline. IDSA, Infectious Disease Society of America. This guideline, it was came in 2007. And there is Indian guideline, Indian ICU guideline, which we have read in Vedanta from our Yati Mehta sir, and his team has made one of the guidelines that is there. And another is, you can see in the book Harrison. I'll show you in the Harrison book as well. So majorly we'll discuss about the IDSA guideline, that what can be done, what are the treatment options. Okay. First, anybody come to you is well healthy person, young, but he is getting pneumonia. The first choice you can give is just only azithromycin, macrolide. First, a person comes to you, is neither extreme of phase, no any comorbidity, he was healthy, not exposed, not has been admitted in the hospital, no antibiotic in previous 3 months. Just azithromycin will cover this Strep pneumoniae and atypical organism, this mycoplasma, chlamydia, okay, legionella. This will be covered by this azithromycin. Okay, even sensitive Streptococcus pneumonia will be covered by azithromycin. Okay. The second step will be any person that has come to you is extreme of phase. All the people have this comorbidity like COPD, will be there, lung disease, heart disease, liver disease, diabetes, alcoholic, cigarette smoking. Then you cannot trust on only just one macrolide. You have to give beta-lactam, beta-LACTM, beta-lactam. That is amoxicillin with addition of clavulanate. So clavulanic acid plus macrolide. That's macrolide includes azithromycin. So this was one option, that clarithrol is also. So first, anybody comes to you, if you have known that there is no any comorbidity, he is well healthy, young, but get pneumonia, you can treat with azithromycin for 5 days. Okay, but if he is having any comorbidity, any risk factor, then you will give a combination of beta-lactam plus macrolide. That you have to give, not only one, 2 drugs will be given. Okay, another option is, or you can give 2 drugs, or you can directly go for the respiratory quinones. The advantage of respiratory quinones is that you can give a single drug. Okay, and disadvantage is when respiratory quinones include levothyroxine. levofloxacin, moxifloxacin, gamifloxacin. Normally these two are used. So levofloxacin dose will be for adult is 750 mg OD. It is never 500 mg OD. You have to give 750 mg OD. Okay. That you need to be considered. Okay, that is very important. Now the thing is that what is the disadvantage? It should be always be used only when your this penicillin group of drug. This penicillin group of drug is if you are getting allergy to this then only think about this fluoroquinolone. Why? Because fluoroquinolone has anti-TB activity. When you are going to give a drug that has anti-TB activity, and I have already explained in previous lecture that we are in a zone of endemic area of tuberculosis. Now somebody comes to you with a pneumonic feature. We don't know he or she have TB or not. You have not evaluated for that. Then before evaluation, if you are going to treat with levoflox, there will be the improvement. You will discharge the patient. You will go to the home. But as soon as the drug will be stopped, because your duration will be 5 days only, 5 to 7 days, you will come back with the symptoms. That is because he is having TB inside there. Now the TB, you will get resistant to this drug. Important thing is that you cannot treat TB with a single drug. So always there will, if there is a penicillin allergy or you have ruled out the tuberculosis. Tuberculosis you can easily rule out by sending the sputum sample for your AFB stain and gene export, also by symptoms, and evaluating checking the deep history, clear and deep history of the patient can help us to rule out the TB. If you are ruling out the TB, then you can go for the respiratory fluoroquinolones. Okay, so this was outpatient. This was also outpatient. Now when you come to the inpatient, when we have admitted the patient, now what will be the treatment option? For admitted patient, again you should go for, if it is in non-ICU, admitted, hospitalized, but non-ICU. So you can again go for beta-lactam plus macrolide, right? Or these two combination, or respiratory fluoroquinolone, respiratory quinolone. The important thing is that now your beta-lactam initially in outward patient was amoxicillin. Was your amoxicillin. Now the patient is what? In the hospital, non-ICU but hospitalized, inpatient. So you can shift this beta-lactam with ceftriaxone or cefotaxime or ampicillin or artapena, artapena. So since now he or she is in the hospital, you can give the antibiotics. So directly go for ceftriaxone, cefotaxime, ampicillin or artapena, any of this plus a macrolide. That will be a better option, because you don't know he or she is having till now having this TB inside it or not. You have not ruled out. If you have ruled out, you can trust for this also. Directly in inpatient also you can go for that. Okay, but when this comes to hospitalized plus ICU, then you cannot go for respiratory quinolones alone. You can trust that. For that, either you give beta-lactam plus macrolide, or you give beta-lactam plus respiratory fluoroquinolone, levoflox or moxiflox. Are getting point. Unless he is or she is in the ICU, If he or she is in the ICU, then levoflox or respiratory fluoroquinolone cannot be given alone. It should be given in combination of the beta-lactam. Beta-lactam can be ceftriaxone, cefotaxime, ampicillin, or tapena. This depends upon the choice you will make. Okay, this will cover what this all the drugs what I have discussed will cover your strep pneumonia, mycoplasma pneumonia, Haemophilus, chlamydia, respiratory, strep pneumonia, Percussion, influenza, legionella, everything. Streptococcus pneumonia, if Staph aureus is to be covered, amoxicillus galvanulinic acid has increased the sensitive one will cover that. Legionella will cover, gram-negative, many sensitive bug will be covered since he or she is from the community acquired. We will talk about the resistant bug when it comes into the hospital in the hospital acquired section lecture. Okay, then Haemophilus influenza will be covered. Okay, but it will not going to cover you this Pseudomonas aeruginosa and community acquired emulsion. For this, we will come and discuss the last one. So now, Pseudomonas. For Pseudomonas, normally we are thinking that he or she is from the community, then we'll think it is a sensitive one. And since sensitive one, then what are the treatment options will be the piperacillin plus you can add tazobactam. Okay, then will be ceftazidime, then cefepime, imipenem, meropenem. This will be the pure. If you are isolating the Pseudomonas from the respiratory sample, then you should use one of these: piperacillin, tazobactam, or ceftazidime, or cefepime, or imipenem, meropenem, or according to the sensitivity what we have obtained, plus a macrolide. That is azithromycin. Or you can add respiratory fluoroquinolones. Respiratory quinolones. That is levoflox or moxifloxacin. So you can manage this Pseudomonas infection now, because you have already admitted the patient. He is in the hospital. You have already identified the organism. Now you can use this, or if there is any risk factor for Pseudomonas infection. If there are the risk factor for Pseudomonas infection, there are many. Okay, so he or she will need this coverage as well. Okay, now come to the last but not the least about the community acquired MRSA. Community acquired MRSA, that is CA-MRSA. Now I have already told that it is more virulent than that of the hospital acquired MRSA. You should always remember that whenever any person comes with a Staph aureus MRSA infection, then you treat the patient. After treating, you also have to remember that he or she needs to get decontamination of this Staph aureus from his body. The usual site of contamination are nose, axilla, and groin. Okay, so what we'll do after treatment, the decontamination includes that you give mupirocin ointment into the nostril for 1 month. This will apply locally in the nostril for 1 month, and the groin and axilla and groin should be washed. It is called chlorhexidine wash. That is normally you use in the hospital are 1 to 2% chlorhexidine. That is not the what we are going to use for this decontamination. It is 4%. It is available in the market. You go, because the 4% is get diluted and used for other purpose in the hospital. You directly obtain the 4% and do the chlorhexidine bath of axilla and the groin for at least 14 days. This is the decontamination. Mupirocin for the nostril and chlorhexidine bath for the groin and axilla. Okay, so that is decontamination. But how we can go to manage the community acquired MRSA? For that, you can go for vancomycin. This will cover this MRSA plus, but it is not going to cover the toxin production. You always know that MRSA the Staph aureus become virulent because it is itself a virulent organism and it will be killed by this drug, but vancomycin, but it does not inhibit the toxin production. So for toxin production inhibition, you can use clindamycin. Okay, or you can directly go for the linezolid. This linezolid has two properties. It is going to kill your bugs as well as it is going to inhibit the toxin production. Kill the bug as well as inhibit the toxin production. So there are two benefits, but again the thing comes again and again that this linezolid has anti-TB activity when you are going to use, and if you are not ruling out the tuberculosis, again you will improve with this linezolid, but you will be partially treating the tuberculosis. That is very bad, because next time after the course of completion, when you will come back, you or she will have this resistant to this linezolid, so it will be difficult for treating the drug resistant TB. And you be sure we have managed a lot of drug resistant TB in Vedanta, and this thing, it is very difficult for patient as well as the physician to manage the drug resistant TB. Okay, now we can there are few things in the this is Harrison. You can see that there is one table indicating the organism, outpatient, non-ICU and ICU that I have discussed already. Then there is one table about community-acquired pneumonia and their risk factors and the possible organism. That also you should know. You should need to know, because it will help you to think when a person comes with the risk factor. Then you have to narrow down what will be the organism. And there are a lot of that: alcoholism, Streptococcus pneumonia, oral anaerobes, Klebsiella, Acinetobacter. You go through it. COPD patient, Haemophilus influenzae, Moraxella, Pseudomonas aeruginosa, structural lung disease, this Pseudomonas aeruginosa, Bartholleria, then Staph aureus, then lung abscesses, travel to these are from their US only, Botulis, Legionella, then exposed to the bat, Histoplasma capsulatum. Look, Histoplasma capsulatum, this Histoplasma, Blastomyces, Coccidioides are not only found in USA, they are also, your person can also present you with this infection, because the Ganga rivers are found to be endemic zone. The bank of the Ganga are found to be endemic zone of this histoplasmas and other fungus. Okay, so that is there. Then the management, these are the risk factors over there. Community-acquired pneumonia, what are the risk factors? Okay, and the most important is the management part. What I have discussed you about the management, there is a clear chart in the Harrison about empirical antibiotic treatment of community-acquired pneumonia, and the same thing I have discussed you here. Okay, so if a patient is, then other supportive measures like oxygen therapy, hydration, you must maintain the hydration, because there is a lot of water loss from the respiratory system. We already know that there is water loss from the respiratory system, and during trachea there will be more water loss. Okay, so to maintain hydration, oxygen, assisted ventilation, and other support if he or she required. Okay, if although not improving, then you have to think for other thing as well, as like lung abscess is there, or empyema had developed, or other non-infective cause of this pneumonic feature like pulmonary edema, pulmonary embolism, hypersensitive pneumonitis, then lung cancer, radiation therapy, etc., etc., etc. Okay, so I hope now you will be able to manage a community-acquired pneumonia patient in our setting or in the hospital. If you have a problem, then call me. Okay, thank you.